Ladies and gentlemen, good afternoon and welcome. We are so delighted to have you here today in this special side meeting on Beyond Borders, Telemedicine's Triumphs, Trials, and Tomorrow.
Hello, everyone. I'm Dimple Bhutani.
And I'm Ryan. We're both from HITAP, and we'll be your hosts for today.
So Ryan, did you know that before the pandemic started, there were a few countries like South Korea where a doctor was not even legally permitted to consult a patient, not even a teleconsultation?
That's very interesting. I really like that because it's interesting. I read a paper recently by McKinley that 80% of people have at least one telemedicine service in their life. And more than 50% actually prefer telemedicine services over traditional medicine.
Yeah, that speaks the volume about the transformative role that digital health is taking place. The landscape of healthcare, particularly digital healthcare, is rapidly advancing, and telemedicine services are at the forefront of this transformation.
Yes, and today the objective is to bring together stakeholders from different perspectives, different backgrounds, and to provide a platform to learn about the implementation of telemedicine. And we are going to hear the trials and the experiences from different perspectives.
So before we begin, we quickly want to remind you of some ground rules. Yeah. So we want to remind you that this side meeting will follow the Chatham House rule. That means that while the information shared can be used, the identity and affiliation of the speaker must not directly be quoted. This creates an environment where participants can speak freely as well as share their thoughts without any hesitation.
Thank you, Dimple. And as well as you can see the QR code in the back of the room and here as well. Because we will be recording, we would like to ask for your consent. You can also find reading materials as well as the agenda for today's program. Now without further ado, let us get started.
So today we have a very interesting line of speakers who are present here with us, and we are very fortunate to have them. This would be, so the speakers would be sharing their journey of implementing telemedicine in their own countries, as well as through a different perspective and lens. And this would be followed by a moderated panel discussion that would be led by Mr. Ali Habib. Now, before we go and dig deep into the telemedicine landscape, we also want to understand what telemedicine is under the pretext and the broader umbrella of digital health, as well as why we are here today gathered in this room. So let us invite Mr. Annapurna Prakash.
Ms. Annapurna Prakash is a senior associate at HITAP, and her work essentially revolves around providing support for the World Health Organization country cooperation strategy under the WHO CCS. And her work focuses on telemedicine services here in Thailand, as well as other low-middle income countries. On the stage here, Ms. Annapurna.
Thank you, Ryan and Dimple. Good afternoon, everyone. So I am Annapurna Prakash. I'm from HITAP, and today I am tasked with giving you an overview of what digital health is, definitions, concepts, and go over some of the determinants that are commonly seen that tends to affect digital health implementation in different countries. So before we get started, why don't we try to get acquainted with each other? So can I please ask every one of you to scan this QR code and use this as a platform for interaction throughout this session. So I can see a lot of thumbs up, so I'm assuming everyone was able to scan the QR code. If not, you can even go to www.menti.com and enter the code here to get into the site. All right, so let's get a little acquainted with ourselves. So can you let us know what the organization that you represent, which organization or what role that you are in right now? Yes, so your current role in your organization? All right, we have researcher, we have data analyst, we have somebody from health sector, coordinator, digital chairman. All right, that's an impressive array of expertise in different perspectives. So we're going to get to know each other, and we're going to hopefully hear a lot from these different perspectives that you all represent here. Moving on, so before we get started, before we dive deep, let's see what brings us here, and I'm going to share you a brief background on our work in digital health. So, to give you a brief overview, the WHO's country cooperation strategy for the term 2022 to 2026 identified different priority areas for Thailand, and one of the priority areas was digital health. And the objective of this priority area was to sort of have a coordinated digital health governance mechanism for Thailand. And in order to do so, multiple focus areas were looked upon. And these focus area looks at open data standards, data policy, security, and the last one is on virtual hospitals and telemedicine. And we at HITAP, we focus on looking specifically at telemedicine to see what are the gaps, to identify a couple of levers or drivers so that we can push the agenda of telemedicine here in Thailand. So that's why we are all gathered here to learn about telemedicine from each other. All right, before we get started, Nandar, may I please request you to go back to Menti? We would like to know what is your level of expertise, or how much do you know about telemedicine? What's your familiarity like? All right. That's an equal split. All right, I'm glad we have 5 advanced level folks out here. Maybe we can hear a lot about telemedicine from you guys. But yeah, moving on, for all of the people who might be beginners, let's look at the concepts and definitions. So we've been hearing a lot about digital health. What is digital health? Anything that falls under the umbrella of technology and health is digital health. But more often than not, there are 3 terms, particularly in digital health, that are often interchangeably used. These are telehealth, mHealth, and telemedicine. So first we're going to be looking at how these 3 words are different. And why do we need to know how these words are different? Because as you might know, digital health is a landscape where we have multiple stakeholders. It might be technical folks, it might be non-technical folks. And we need collaboration across different industries. So in order to foster this collaboration and help with cross-disciplinary communication, it is foundational for us to have standardized set of definitions and consensus on what is what and what something is not. So, first of all, what is telehealth? Telehealth is a subsection under digital health which uses information and communication technology to look at clinical, non-clinical, and educational services. So it's under the huge umbrella of digital health, we've got telemedicine, which covers pretty much everything, clinical, non-clinical, and educational. And under that, we have something called mHealth, or popularly known as mobile health. So what is mobile health? Mobile health does not require, mobile health is a subset of telehealth, and it does not really require a healthcare professional at the other end. So, and as the name suggests, it uses a cell phone. And within mobile health, we have something called telemedicine, which actually focus only on clinical service delivery. So it would be the use of information and communication system for clinical service delivery only. So to put things in context, let's look at how different terms are associated. So we have the broad umbrella of digital health, which is often referred to as e-health also. Under e-health, we've got telemedicine, and with it telehealth, and within telehealth, we've got mHealth and telemedicine. So first is a foundation of what is what. Now that we know what is what, can you please go back to your mentee and let us know what you think are some of the factors that can help in telemedicine implementation? These could be enablers, these could be barriers, essentially the levers that drive telemedicine movement. I can see everyone typing. All right, so there is infrastructure, there's regulation, there is reimbursement, right, policy support. All right, those are very different perspectives, very different elements, and we hope to cover all of these low, patience, internet connection. Yeah, so we hope to cover all of these different elements in today's discussion at the end. So, looking at the determinants, I'm going to be so we've been looking at other countries to see what are some of the common drivers that are seen across different nations that pushes telemedicine agenda. And among other deliverables, other determinants, I'm highlighting 4 determinants here, which are most commonly cited in LMICs. So the first one is data privacy and concerns about cyber security. Then the healthcare provider availability and the change management and how the healthcare providers adapt to the new digital health technologies. The regulatory landscape that enables or creates a barrier towards the adoption of digital health technology. And lastly, interoperability. So interoperability is nothing but how systems exchange information. So in a health system setting, an example would be how the electronic medical records can communicate with mobile apps so that it can enable patient communication across different platforms and make sure that patient information is available at all times. So that's interoperability, and these are some of the things that we repeatedly saw were being cited as challenges or barriers to telemedicine implementation. Now, we would look at how certain countries are actually addressing these challenges. So first one is addressing cybersecurity issues. So there are a lot of ways in which a lot of countries, depending on their context, depending on the resource availability, address these challenges. And here we were planning to highlight a couple of steps or lessons that we learned from other LMICs, which can be used by countries which are setting out their telemedicine journey. So first one, about cybersecurity. Cybersecurity concern has been repeatedly cited as a challenge for telemedicine implementation. And if you are in a resource-constrained setting where there's no enough human resource or financial resource to set up a solely dedicated cybersecurity task force, we saw that in examples like India, a national cybersecurity certification body, which is a small group of experts who are responsible for auditing the telemedicine services. So rather than having a set of folks actually dedicate their time on cybersecurity issues, we have a very niche group of people auditing the services. So that's one way of tackling cybersecurity issues, specifically in terms of human resource. The second one is addressing the availability of HR, human resource, for actually delivering these services. So this, and the lesson that we learned was utilizing community healthcare workers. Again, this is a lesson that we learned from India, where there is a provider-to-provider mode of service delivery. And also this was repeatedly brought up in our stakeholder consultation in Thailand about utilizing community healthcare workers to make sure that our telemedicine services or healthcare reaches the last mile. Then, moving on to, addressing the regulatory barriers. Now, this is very crucial. A lot of countries raise the concerns of regulatory barrier. And one key lesson that we learned from Singapore was exploring new alternatives for regulating services. So in Singapore, what we saw was, apart from the, so in Singapore, what we saw was they had moved on from the traditional service-based, premise-based regulatory approaches to Yeah, service-based regulatory approaches. So what this means is it gives the healthcare provider the flexibility to provide services which might not, and it's not restricted within the four walls of the premise. So exploring these kind of new regulatory approaches can be helpful in implementing telemedicine services. And finally, addressing interoperability issues. It is a very it is an extremely complex issue, and there are multiple ways in which different countries are addressing this issue. But one bare minimum that we saw that most of the countries spoke about was the compliance to international standards on interoperability, so that we have a benchmark to creating an interoperable system. So I know I am running out of time, so quickly wrapping up my key messages. So a couple of key messages from our findings were, one, establishing a standard definition for digital health is foundational. So when we set out our journey for telemedicine service, we need to know what is what and what is not. And secondly, we do not have to reinvent the wheel. We need to be gaining understanding of what determinants, what levers are being faced by other countries and other settings, and sort of develop context-specific implementation plans. So that is the end of my presentation. Hope I've set the stage for the wonderful lineup of speakers. We have a live Q&A wall. So if you scan this QR code, you'll be able to type in any question anonymously, and we'll have the moderator discuss about it later in the open discussion at the end of the session. So that's my time, and over to the MCs.
Thank you, Annapurna. That was really insightful presentation. Now that we know about the definitions of telemedicine, let's take a step back, rewind, and look at what are the building blocks of digital health and how countries can learn from these building blocks in implementing the successfully telemedicine pathways. So we will have our next speaker who will be examining how these digital health building blocks were established and how the countries like Estonia navigated its pathway towards the successful journey.
Yes, that's right. Thank you, Dimple. Dr. Tumas Palu, the advisor on global health coordination in the World Bank office in Geneva and co-led in the UHC 2030 Secretariat and leading initiatives like the Global Actions and Sustainable Financing for Health Accelerator. His extensive experience includes leading health programs in Eastern Europe and former Soviet Union. He holds key roles in the Estonian Social Health Insurance Fund Management Board and serves as the Deputy Director of the Tallinn Emergency Care Hospital. Please join me in giving me a warm welcome to Dr. Tumas Palu.
Well, thank you for the introduction. Since I was in the World Bank, I moved over to WHO, but the title remains the same. I just moved down one line in the alphabet. So, but I think the position, the perspective I'm making this presentation is actually coming from Digital Republic of Estonia. So we built our systems. We are currently a high-income country, but I want to say, because LMICs have been mentioned here, that we built this system while we were still MIC, a middle-income country. So, so it is possible, and I can partly say one of the reasons for success was that we didn't have enough money. To try to build a big system that will answer all the questions. We really had to start from the very basics. So I will be speaking from a perspective, from a health systems perspective. I'm not an IT specialist, just to the extent the kind of my nationality makes me. But so I put this picture up there. This comes actually from a journal article of New Yorker in 2017, which says Estonia, the Digital Republic. And I just want to say that in Estonia, e-health, telehealth is just an application of e-society. We really don't have a freestanding, standalone e-health system built from ground up. It's all linked to the national digital systems. So systems, the legal environment is strong. I think data protection, as already mentioned, very important thing, digital signature. This is a legal signature. You can sign contracts with them. You can sign a prescription. So it has a legal meaning. That is a great enabler. Unique ID. We started early with a unique ID, and now it is the identifier for every digital government service or private service you can use. We didn't have to establish our own digital identity. Authentication, very important. Your systems need to know who is accessing it. You may be accessing it as a patient to see your own data. You may be accessing it as a doctor that gives you right to see the other people's data, health data. But it's using the same ID. It's just in the system, you have a tag that gives you authorization. So that this as a licensed doctor. Computer skills, computer literacy, very important. In the 90s, we were still just out of Soviet Union. We started computer literacy things in our schools, just to build a generation that comes with is comfortable with the digital world. Of course, now we say every children are typically more comfortable than us, but at that time it was not the case. And trust, really important. In Estonia, we have run elections, all our elections are digital in 2005. I only returned to Estonia this summer. I've lived outside in many countries, including in Thailand, starting from 2011. I haven't missed an election. Usually it takes me 3 minutes to cast my vote. But there is a trust in the system, so I can do it comfortably. And then this digital infrastructure, I think that is already kind of mentioned. We call it X-Road, Estonia X-Road. And it has a lot of physical, of course. It needs to reach everywhere. At the time, there was no really 5G or other kind of ways to send data quickly. We called it the Tiger Leap, which was in 1990s. We committed to spend 1% of GDP on building digital infrastructure, and then did it. Took the digital high-speed, secure infrastructure to everywhere in the country. We are a small country, though, so we have to put this qualifier into the on the table. And it's like an interoperability layer. That's a highway that moves from one, connects all the different servers, applications. It gets into secure envelope, the messaging. So it uses the same national identity there. All these different applications use the same identity. And of course, there are the national general standards. And if we get into health, then it really, health standards can come on top of that. Security and certificate, authentication, I mentioned, how to get into the system. But it also, it leaves a track or trail. So I can see who has looked at my e-health record, with who and when. So it leaves a timestamp and so forth. So, and then literally the system has become like an Android or iOS. Anyone can build an application. So of course, once you just cannot build an application and start running it, you need to be certified as secure. So to enter the circle, but they all use the same foundational elements of e-health. So it really becomes an application, and I can say that I'm going to show the applications next slide. But our key e-health or telehealth applications have been all built by different private sector companies. So you don't have to, that your government tries to procure everything in one go. No, you can go bit by bit, but as you have basics, then it's all connected. So let's look at this Estonia, what do we have? So early on, I was in the Estonia Health Insurance Management Board. What did we, early applications, this was like late 90s, early 2000s. In health insurance fund, first thing we did away with a health insurance card. We have a social health insurance system that depends on whether you're employed or not. Or whether you are. So if you give a card with a validity of 2 years, the person may leave the job next day and then the card doesn't matter. But if you have a unique ID linkage to the social protection or social systems, then you know real time who is employed or not. And you go to, only thing you have to go, you to a healthcare provider and say, this is my identity. And they will see insured, not insured, and so forth. We have a universal coverage, but still about 5% of population may be uninsured at any time. So PACS, the digital picture archiving and communication system, that was very early. That providers started to do it. It was not national in the beginning. The big hospitals started to do it. And very quickly we digitized the transactions in social health insurance. But every transaction again was linked to very concrete patient unique identifiers. We actually have our database that was around individuals. We knew I could ask any analysis, and in 2 hours I get the cut. By gender, by age, by location. So very easy to do. Then in 2007, electronic health record. That's you discussed. But that was really provider focused. Provider can use the data. Basically, it becomes a compilation of the data. Big mistake that we made, it's all text. So 15 years later, you have a bunch of PDFs in your system. If you want to look at the patient history, very, very difficult. Need structured data, at least for, I don't know, things you can measure, blood pressure, weight, lab. I think that every lab system can now produce standardized data, but that we didn't have in the beginning. So, but we didn't know it. In 1 year, you think you're doing fine. You're just 1 or 2 episodes there in the system. So now, of course, the EU is implementing cross-border data, and patient summaries is one they want to do. E-prescription came in 2010. It's a big success story, and it's also now picked up by EU. And it comes with decision support. So that's if you physician does everything in digital prescription, then it's monitored by decision support system, and flags go up if there is a potential problem, conflict with some other medications you have or some other things. So and then of course pharmacy can dispense with any pharmacy. They can look it up from the cloud and dispense the medicine. E-ambulance, this is more recently, that means that ambulance, if they go for a call, they can real time look at the patient record from the site. And also there is provider to provider e-ambulance consultation. In important cases, you have a backup in the hospital. You can send your electrocardiogram reading or something else and get the immediate response from because you have paramedics on the ambulance. E-consultations. Now, 60% of all primary healthcare consultations are remote, video or audio. And it's becoming a concern because people are now thinking they don't get any FaceTime with their primary healthcare provider. And they're now trying to use some e-triage system. So I think it's going to the other oversight. So, but I have to say that all of these things, they all require this to work, that you have this basic underlying digital system, because you need to be able to identify your patient, you need to be authentic, be securely access the system. It is all the same architecture. All these applications have been developed by different private sector firms, but then picked up, go into the utility use in the health system. Leadership and coordination, very important. E-health, we had e-health foundation in the beginning. It was a kind of not-for-profit body, and then but taken over by Health and Welfare Information System Center that is across the social sectors, because now it's also clear that it's not only e-health you need connections with social assistance and labor systems. Now from electronic health record this year, or last year, we moved to a new concept, what you call health portal. This has both retains the provider focus. Provider can get all their information, but it now also has a patient focus as well. And if I have time, I can quickly try to demonstrate, because it kind of shows some of the building blocks as well. But I need to go to the where the presentation is. I will keep talking. So. Can I?
You might have to duplicate it.
No. Okay. Okay, that's the e-portal from a patient perspective. I will log in under my name, but I can say that it provides you some relevant that is not allow necessary cookies only. The that is not individual, right? Breast cancer screening, it gives you the years that you are called more broadly. You gives you news, data secure, like tell us if patients are worried about their data privacy, then they can read it and get some assurances. And then, of course, you go to the portal itself. I tried to log in. So I want to say this is authenticated by the state authentication service. It does for every application, not in health. You don't have to help us. We don't have to set up different ways to log in. It is secure. We have 3 ways. I use the Smart ID. It asks for my, let's see, put it in English language. That is linked to my mobile phone. Again, my unique ID, which is it's not secret, everybody can look them up, so don't say that I put something comfortable. It's my birth date, for example, my gender. So I get the notification on my mobile phone that I'm doing now. That is ask me to authenticate. That it's me. It wants to align the codes that I see on the screen that is also on my mobile phone. And then I should be able to should switch the screen. So I'm in. So it's my name. I'm uninsured. Don't worry. This is social health insurance. I'm not employed currently in Estonia, so but I have a different insurance. But it doesn't matter. This is my family physician with a phone. It has my last use of services. It tells me that my vaccination recommendation. I'm in a risk group for COVID-19. Suggest I vaccinate. I've done it because these actually are visits for the vaccination. It also often, I think it's important that tells you, and this doesn't come with the insurance status. It also tells what insurance pays for your care. I think it's very important. Often people think that they're not getting, but you can see the bills that have gone out for you that is being paid. So, and there are, you can go and check your the outcomes of your visits, the lab tests, or it tells you show summary, what the provider has put in there. So X-ray from the electrocardiogram and so forth. So you can see, and of course other doctors can see it well as well. So it is more like a patient and provider oriented. I go out now, so and you can switch it back. I have one more slide to go, and that I'm done. But that's the same. I do the same thing when I participate in elections. It's very quickly. So I also was asked to do the kind of lessons learned from Estonia, if we would like to say. They all been mentioned already. They all been mentioned. So just to recall the leadership, literacy, trust, underlying digital infrastructure in the country. We really in Estonia only need to play health specific applications. You don't need to worry about the basics. The e-health applications are really important. You can't do telemedicine if you don't have the basics. Otherwise, you can build a siloed system, but then it's silo. But here it's all connected. And structured data. I think if anyone starts now, I would say, like, if you build your e-health record, put as much structured data in there as possible. So thank you very much. I hope it was at least mildly interesting.
Thank you so much, Dr. Thomas. It was indeed insightful and to learn that from a country like Estonia, who was like decades ahead of many countries. It's really eye-opening that even like Estonia had to transform from e-healthcare records to e-health portal. That means like digital health in itself is a transformative journey. Now that we have heard from you, we would like to learn from how a country that is not that advanced or has not laid out their building blocks or doesn't essentially have matured building blocks, how startup companies and innovative technological companies, how do they enter the market, and what kind of incubation that we need to provide to them. So our next speaker would be our next speaker is a very interesting one who would be talking about innovation as a catalyst and would be sharing her perspective from Singapore and talking about Singapore's journey towards health technology sandbox.
Allow me to give a bit of introduction. Ms. Chi Ling is the founder of Equitech Collective in Singapore. You'll learn more about it in a few seconds. Formerly Deputy Director at Open Government Products, GovTech Singapore, and she has played key roles in healthcare technology innovation. Between 2020 and 2022, she served concurrently at the Ministry of Health and Smart Nation Digital Government Group. She also led the creation of Healthcare Technology Sandbox, as Dimple mentioned, to modernize the digital health systems. Recognized for her impact, she received the Singapore Computer Society 100 Women in Technology Award in 2021. Please welcome Ms. Chi Ling.
Hello. Hi, everyone. How's lunch? Hopefully not too much food coma. We've got 2 more exciting presentations lined up, so I'll keep mine pretty short and sweet. So like our host mentioned, I am from Singapore. But I've recently started working more in our region in Southeast Asia to build digital health record systems for low resource settings. So for underserved communities who may not have the resources to purchase prohibitively expensive products or systems, I think there are certain alternatives we've been exploring. I'll share a bit more about my journey in digital health, starting from my time in the Singapore government. I now belong to a group called Acritech Collective. We are called Acritech because it's a concatenation of equity and technology. We think there's a lot of potential, right, to see what works in the developed economies. In Estonia's case, we've seen how mature some of your e-health systems are. In Singapore, we also have a lot of, I would say, digital health resources. But today's presentation, I really want to see how we could borrow some learnings from high resource settings to see if we could do even better with less. So my digital journey started when I was an officer in the Ministry of Health in Singapore, and shortly after I joined the technology side of things, COVID-19 broke out, and I was tasked with a mission to build a vaccine appointment system. And I remember falling off my chair when I was told I was given 2 weeks to stand up a team and to build an end-to-end vaccination appointment system for a country of 5 million people. And the mission then was, we want to get people vaccinated, hopefully 80% of people vaccinated within the first 9 months, and of course, eventually 100%. We want to minimize wasting vaccines given a limited supply. At the time in December 2022, if you remember, the vaccine supply was in great shortage, right? So the first stockpiles got to Singapore around Christmas, and our team started working basically round the clock and skipped New Year, basically. And we wanted to also give priority to those at risk. So it wasn't just about giving vaccines as people came, but prioritizing elderly, seniors, healthcare professionals who work in more at-risk settings, students as well. And also triaging to make sure that pregnant women at the time, it wasn't very safe for them in the initial days, right? So making sure we were careful about who we administer it to. And finally, to ensure smooth traffic. It would be very, very disastrous and ironic if when people went to get the vaccines, they get COVID, right, by standing in line in crowded vaccine centers. So that was all very important. What we need to do is then to have a way of creating digital health tools or technology to make sure that the limited supply goes to the people who need it the most at the time. So what did we do? It didn't, they say Rome wasn't built in a day. I think to have to build this in 2 weeks meant that we had to form a team of about 5 to 8 engineers initially to come up with an end-to-end journey. And this is what we came up with. First, of course, you hear about the vaccine program through the news. We'll visit the website. We get notified on our mobile phones via SMSs. And then that gives them a unique link to fill up a health screening form. And we made sure to secure 2 doses for every individual. Different countries do this differently, but the efficacy of the vaccine was greatest if you do this within 21 to 28 days. So that was also an important parameter to make sure we include it in our system. So this entire patient activation journey didn't really, as you could imagine, tools or systems weren't built for COVID. There weren't such a vaccine appointment system that would do mass notifications and mobilize the entire nation to get vaccinated. It was also unusual at the time for a government to push notification, right, straight to your mobile phone. Usually you hear it from the news and you go to a website and you log in or you sign up for something. But that was a more passive approach to disseminating information and bookings. So this approach of actually pushing notifications directly to people, having unique booking links was one of the features that really helped initially to jumpstart vaccine appointments at a time when there was vaccine hesitancy and people weren't really very willing to get it. So I previously came from this experimental tech team within Government Technology Agency of Singapore. And we ran in these small technology teams of about 5 people, maybe 1 product manager, 3 software engineers, 1 designer. Typically what happens is technology is all the way at the very end. After policy, operations plans are in place, and then they go, oh, we need software. Like, let's go find a vendor and get 3 quotations, and by the time the vendor comes around, the project specifications are written, 3 months passed, or maybe sometimes a year has gone by, right? There was no time to lose or to waste during COVID. So what usually happens, which is this waterfall of policy, operations, product requirements, procurement, design, engineering, and then testing, had to be really collapsed into an integrated team that's working together all at once to deliver the outcomes for this mission. And it's more akin to, I would say, jazz bands, improvising, playing jazz, than an orchestra where we have sections and different instruments and a conductor that knows everybody, or that knows everything. So it's, as a muscle of moving quickly and nimbly, that's something that I think a lot of governments and bureaucracies struggle with, including Singapore. This is not exactly second nature to us. So during COVID, we were being quite experimental. So I think our host mentioned the word sandbox previously. It was quite deliberate. I think when I first wrote the proposal to set up this sandbox within the ministry, I basically asked my bosses, just give me 5 headcounts. That's all I need, right? 5 headcounts, and we're going to be, I can't, there's no plan because there's no project requirements. We don't know how the COVID-19 virus is going to unfold. So we're just going to have to play by ear. So why a sandbox? Because one, a sandbox is necessary when the parameters are not well defined, when a mission direction can change rapidly because of COVID or other extenuating situations. A sandbox also because there hasn't been a precedent for this kind of approach on the right-hand side, for all these expertise to come together moving fast. So it's also important because getting the policy folks and the communications folks to go, hey, actually, we have to work together with the tech and make sure that we announce and broadcast the right messages based on how the tech's built. That's quite unusual, right? So when we set this up, the idea is that we can relax some of the rules. You can build almost anything you want that works. And in a safe environment with clear boundaries and safeguards, the consequences of failure could be contained. Of course, nobody knows if we could finish it in 2 weeks. So there was some contingency planning as well. Like if we don't, what is the manual workflows? Some, I think, countries defaulted to Excel spreadsheets, for example. Not absolutely a bad idea, but it's not as optimal. So that could be a contingency plan. But basically, in a given sandbox or innovation technology sandbox, you would relax certain structures or rules or even stovepipes within an organization. It's very, very common for governments or big organizations to go, okay, finance team is this team. You have HR or comms or policy, and they all have their reporting structure. Getting them staff to work together in a way that circumvents or almost transcends these bureaucratic interests is new to some extent and necessary in a case of crisis. So that was the work back in Singapore, and I think what happened after that, there's a silver lining that comes from COVID-19, which was, my apologies, I think it's going a little wonky. Okay, let's come back here. All right. There's a silver lining in the whole COVID-19 episode, which is that a lot of the technology that we built stayed on, right? So the appointment systems that we built for COVID-19 was repurposed into something that distributes pneumococcal vaccines. It's now called the health appointment system, which enables people to book appointments for any health services in Singapore. And the idea of push notifications actually stayed, right? So today, if you were above the age of 65 or 70, you actually get push notifications to say, hey, it's time to get your pneumococcal or flu vaccine. Now that's a qualitatively different user journey and experience from what happened before COVID, where basically you rely on TV or radio saying, hey, please, if you're of this age, go and book. And that takes a lot of time and effort for you to even find clinics where they offer this vaccine. So that's the Singapore story of what happened during COVID-19 in the case of vaccine appointment systems. There were also a lot of other digital health solutions that came up, but I didn't share on the slides, but some examples, just to share quickly, is around home recovery programs, right? How do you enable swift quarantine of patients through timely notifications? Another example is also reducing the time for COVID-19 results from 3 days, right, to reach a patient to 3 minutes. If there's anything that changed in the health landscape is, I think Thomas in the previous presentation talked about how the evolution of electronic health record systems being a clinician-facing project to also a patient-facing project. That's really important. And I think generally there has been that shift in consciousness that really the end consumers shouldn't just be healthcare professionals, but also users, all of us as patients or people. That patient centricity, I think, will be one of the enduring features or silver lining that came out of COVID-19. Okay, so I'm going to switch gears a little bit because let's move away from COVID. I think we all don't want to hear more about COVID anymore. Hopefully that's behind us. Fast forward to last year, I started, tinkering with the idea of innovation sandboxes elsewhere in Southeast Asia, outside of Singapore. And one of the pressing challenges that we face in our region, especially in Thailand, is the influx of refugees and migrants as a result of border conflicts in Myanmar. I think it's really a tragedy of our time that I think is sometimes really underreported. And there are a lot of underserved communities, migrant communities along the border, last I heard, about 4 million people without access to basic healthcare and public health and education infrastructure. They are sort of in this twilight zone, right, of not being able to go home, but also being in a different state where they aren't recognized, they're not documented. So this clinic I work with, it resides along the Thai-Myanmar border. It serves about 200,000 patients. And when I first visited about a year ago, this was how they kept the records. So everything's pen and paper. Every patient has his own folder. And when you visit, you have this hard copy card that you bring. And the way an ID is issued is, those stamps. You just tweak and you add one, and that's your ID. Right? It's not computer generated. A completely manual work process, right? And so I thought, there's got to be simple ways of building a low-cost electronic health record system that obviously we're not going to charge migrants and refugees to use this system. So to keep it really simple, keep it really low cost. In most hospitals in Thailand, it costs about 20 million USD to 200 million USD to set up a health record system. Our challenge was to do that at a low fraction of the cost and to build local capacity so that even as the engineers from my team from Equitech Collective leaves, they can sustain the system beyond us. So 9 months into the project, we have actually both a mobile and a desktop version of this electronic health record system that enables all the staff to key in the diagnosis, the medical histories, and even take patient vital signs more systematically. There's also an ID card that every migrant and undocumented person now has access to retrieve their health records easily. And that's a sea change in a clinic operation that definitely cannot afford commercial solutions that's typically prohibitively expensive. All right, so that's our work in Thailand. How it relates, I think, to this innovation sandbox is it's not so different if you think about how in COVID-19 in Singapore we set up these integrated teams to build systems. In this project, it's not the case that we went in with a predefined solution. In fact, the staff themselves take full ownership over the entire process of change management. Technology implementation is 80% people, 20% tech. If you can't get the people buy in to the changes in workflows, changes in roles and responsibilities, the solutions you deploy is not going to last. It's not going to stick around. So, when agri-tech comes into some of these settings, a major priority is really in what are the resources around, by way of leadership, by way of staff, learning, aptitude, eagerness to change, and we work from there. We don't go in thinking, we are here with the electronic health record system. All right, we start from where they're at. So one example is we've had to do typing competitions, right? So after work every day, the clinic staff will come together to learn how to type. Yeah. So I'll just skip ahead, because I think we're running out of time, but just leave you with two reflections. Simple is that better than complicated. You can make pasta with a pasta machine that is costing 100x more than basically a rolling pin that allows you to make fettuccine, spaghetti, and all sorts of pasta. Same thing with technology. You don't need to be overly complicated in the ways we think about technology. A lot can be achieved with less. This one I think I talked a little bit about, so I'm just going to skip this. So I think I'll leave the rest of time for questions and for the rest of our speakers. Thank you.
Now that we understand the significant role that a sandbox environment plays in success of telemedicine, one might also question that there are other factors such as engagement strategies, particularly when it comes to engaging with government. So with our next speaker, who comes from PATH in India, which has been instrumental in integrating telemedicine services, particularly in remote areas, he will be highlighting about with his extensive experience to discuss these aspects.
Yes, that's right. So Mr. Samir Kanwar, the next speaker, has been the Director Digital Health, India and South Asia, or PATH, since May 2022. And he was the Director of Information Communication Technology for UPTSU with IHAT. And he has more than 31 years of experience, which includes social sectors, digital health, startups, IT, telecom infrastructure, and other networks. In the past, he has handled a leadership role as Head National Nutrition Resource Center at the Ministry of Women and Child Development at India. Please welcome Mr. Samir Kanwar.
Thank you. Thank you very much. And good afternoon, everyone. I'll just change my position so that you can roll your heads a bit. Okay. I didn't know I'm going to wear the same suit as in the picture. And before you think I'm wearing an old one, the picture is just about a month back. So, okay. What I'm going to do is I'm going to probably leverage what Thomas has already talked about in terms of the infrastructure piece and what we in our parlance call as the digital public infrastructure, because that has to be in place before we look at digital health in any form, right, comprehensively. I'll talk a bit about what we do at PATH and how do we support various governments, and then I'll jump into the very specific piece of telemedicine. Okay, so I think we've already gone through this with what Thomas talked about, right? We started off somewhere in about 2000s, and this is a generic side, right? We looked at digitization, which was largely, aimed at capturing data in some form, right? And this was siloed, totally siloed. We moved on to a bit of democratization where we said, okay, we're getting more technology into it. How do we get more people involved, in use of technology? So we reached out to the health workforce. Third, somewhere around 2015, we started talking about interoperability and the issues of siloed systems. And I think it required a COVID for us to realize that probably, we need to really leapfrog if you are looking at being able to handle the upcoming health challenges, because COVID is not going to be the last one. This I'm drawing an analogy from what happened in India, right? And, this is the sectorial adoption of technology in India. Now, you see this pyramid which is going up, right? And unfortunately, what you find is that the health sector is the last one in terms of adopting technology. Something like as complex as real estate and the financial sector and the retail markets have all adopted technologies much before, the health sector. And this is applicable across countries. There are very few examples of Estonias and Singapores, right, in the world. Even advanced countries are struggling to, look at digital health and adoption across the entire spectrum of healthcare, right? And we are already glaring into the AMRs and climate change and One Health, right? So it's going to get more complex as we go forward. Okay. Shifting gear, what do we do at PATH? And this is very specific to what we do in South Asia and Southeast Asia as well, because that's how we look at digital health. We have 2 regions as far as PATH is concerned. We are a global organization, work in about 75 countries. We have offices in about 25 plus countries, and as regions, we work in 2 regions. One is the Africa region, and the second is the Asia, Middle East, and European region. And we look we look at digital health for the entire AME region, what we call as the Asia, Middle East, and Europe from India. What we aim at is, engaging the stakeholder, and this includes the health workforce as well as the citizen. In terms of the journey for digital health, what we are looking at. We are looking at digital for scale and sustainability, which leads to impact, all right? We firmly believe that, pilots never fail, but pilots never scale, all right? So we look at scale and sustainability when we look at supporting governments across. And obviously, we are looking at equity, we are looking at universal health coverage, and how can we use digital as an enabler to achieve that in a quicker time frame, right? We have presence in 6 South Asian countries in terms of offices, very specifically for digital health. We work with the government of India, being our largest, engagement. We have presence in more than 8 states within India in terms of digital health. We get support from almost all organizations in terms of the donor landscape. Okay, I'll just skip this slide because I think we've already talked about it and go to something which is more interesting and more engaging, right? I'm going to talk about 8 pieces of work which we are doing with the government of India, right? And this, lends much to what Thomas has already talked about. So India launched its digital health mission in 2021. And what the government did smartly was to set up this digital mission outside the government of India because they wanted it to leapfrog and fast track, right? The speaker before me from Singapore was talking about, the kind of normal procurement processes which we have in the government, which take a good about, let's say, from, if you are lucky, from 3 months to about a year, right? By the time you already lost so much in life, right? So this was launched in 21, and it used a very similar landscape of what Thomas talked about in Estonia in terms of using the existing infrastructure which India had built. We are looking at a population, just to give you a context, obviously we are the largest country in terms of population. We are looking at 1.4 billion people, out of which 1.31 already have a unique identity, right? So that has taken us almost like 20 years to build, right, that ID. Second is, there's a universal payment gateway which exists in India, because if you are looking at teleservices to get into action, and during COVID, because we were not able to move around, so this became extremely handy. Just to give you a context, the universal payment interface in India does 10 billion transactions every month. That's 2 billion more than the population of the world, and this is done every month, right? And this is again, cross-sectorial. It's nothing to do with health, right? Very specifically for the health, what the government of India is now doing is building up something known as the universal health interface, very akin to the payment interface, so that there is an exchange of record which happens irrespective of where the patient is, whether private or public sector. Second, it is doing is also, is to build something known as the health claim exchange, which largely looks at making your claims transparent, whether you have a private sector insurance or you are supported by the government and you have a social security scheme in your name, right? So it's making that system extremely transparent. I'll move on to the second one, which you see on the lower, is as far as India is concerned, and largely all LMICs are concerned, our 60% dependency of healthcare delivery is on the private sector. So the government of India realized that, or the national authority which runs the digital mission realized that, unless and until you engage the private sector, it's not going to happen in a country like India, as vast as India, as diverse as India. So we did a pilot with them to engage in one of the cities in which we reached out to the doctors who are one-room clinics. We were not looking at hospitals because we know the hospitals will in any case at one day come into the gamut of digital health, because they have huge pockets, right? Similarly, the public health sector hospitals will be pushed into adoption of technology. Just to give you a context of numbers, so overall landscape, if you look at in India, we've got about 400,000 clinics and hospitals, secondary and tertiary care. Out of this, about 50,000 are secondary tertiary, which leaves about 350,000 clinicians who are practicing in their own clinics. So until you engage the 350,000, it's not going to work. Now, what the government of India again did very smartly was, when we did this pilot, we started engaging and we had those tech platforms for the doctors to adopt on a daily basis. Is at a certain amount of time when we did the pilot, we had those records coming in, they incentivized the private doctors. And I don't know if you got a use case anywhere else in the world wherein the government is paying a doctor 20 rupees, it's a very small amount, 20 rupees for each electronic health record which he was generating, if he was generating minimum 100 records in a month. And similarly, the tech provider, who was a private provider, and government was not involved at all, is being paid, when I say, it was not was, it is being paid, is 5 rupees, all right? Now, when this pilot became successful in one city in India, what they've done now is they've taken ownership, and now they are funding 100 such sites across the country, right? We are supporting them in almost like 60 of them. This project is again for 1 year, but then, India is extremely large and extremely diverse. So if I look at how much of engagement we require almost like 750 plus micro sites to happen in India if we want the entire private sector to get engaged. We are still at 100. So it's a huge scale which we are looking at, right? Then just moving on to, the regional context, we've done a lot of work in India, Bangladesh. We are now engaging in Nepal. We are looking at urban health very specifically, separately, because what works in rural doesn't work in urban, right? So there is a differentiation when we look at engagement in terms of the digital technologies which can apply to rural and the way health service delivery happens in the urban, at least in India, and largely in the entire of South Asia. And then I'll very specifically come into as to what is happening in the telemedicine, telehealth, or M-health, whichever way you want to call it. We've already seen those definitions, right? An extremely important aspect, we need to also focus on is the global perspective, right? And I think we've got a panel session going on where Alan is talking about the global initiative on digital health, which was launched last year during the G20 presidency of India. And then these discussions started off somewhere in 2022, where we said we need to set in transparencies in the way the countries are funded from various organizations, right? There has to be a transparency because we have been doing duplication, we've been doing pilots, and we've unfortunately, as far as health is concerned, we've not been able to scale them up. So where are things going wrong? Where is the transparency in terms of what the country needs are and what the donor is ready to fund, and the implementation, the availability of implementation partners like PATH, how can they support this entire grid? So, I think it was a momentous moment for us when this initiative was launched, and we foresee, how transparency can be set in by a mechanism like this at the global level. Moving on, we are also doing a lot of work at the primary healthcare level. So we are, in fact, as we speak, we are launching a project at scale in one of these states in Maharashtra to look at how the entire primary healthcare can be comprehensively covered through digital health, right? How does digital health integrate and starting from the the last worker on the field who's probably or she's not probably educated, right, enough to be able to handle technology? How do we engage them, get them on board, and ensure that at the lowest level, when we are looking at surveillance happening at population level, we are able to engage the entire health workforce. So it's just kicking off. It's almost like a 3-year plus project, which is going to happen across 4 districts in Maharashtra. We are hopeful that we'll be able to come up with a model which then can be adopted by other countries. It's a part of the one of the initiatives as part of the GIDH. Going to closely work with WHO to ensure that we follow all the standards which we were talking about in terms of the global standards and stuff like that. Lastly, I'll cover, I'm just skipping that piece in terms of rice fortification because it will become a bit complex and I don't think I have the time to probably cover all. And this is more interesting to probably the people sitting in the room here. We launched an initiative known as the Youth Ownership of Digital Health. And this was largely based on the fact that having worked in this sector, we understand that we do not have the next level of leadership in digital health because digital health was never considered something outside the programmatic interventions of health, right? We've always been focusing on digital as part of programs and never been talking about digital health, like what Thomas was mentioning, that you are looking at health from as an ecosystem rather than looking at it in a silo. Dailies, how many lives did I save in terms of malaria and for example dengue. So we keep working on those numbers, and unfortunately our technology was never out. So we wanted a platform wherein the next level of leadership could start engaging and see as to what are the opportunities, what do we need to work when we look at digital health going forward. And this is for folks, quite a few of you, I am presuming, are less than 35 in this room, should join this initiative going forward. Okay, I'll shift gear and deep dive into telemedicine. Okay. Telemedicine, I think, goes back to the 1940s or 1950s. I think that's the first time it happened, and it was more of a B2B connect, from a hospital to a hospital connect for surgeries and stuff like that, when we did not have the technology to be able to support it. In India, the platform is called as eSanjeevani, which is again a government-owned platform, by the way. Right, and it was not that it has been there for almost like 5 to 6 years, but then unfortunately it took a COVID, right, to show us the value of telemedicine. So it works on two modes. It's got a patient to doctor connect, and it's got a doctor to doctor connect. And it's being pitched as a digital public good now for other countries to adopt. In fact, quite a few, I think there are almost about 8 countries which are already adopting this platform, and I'll talk about the scale to which it has actually gone on the next slide. Very interesting, there was a study which was done in India, in one of the states, where it was seen as to what is the impact of telehealth, right? It turned out, and this is very specific to India, by the way, is that you save a distance of 21 kilometers of travel on an average, right? And you save almost like 940 rupees. This is Indian INR, that's Indian currency, on each consultation. And we are not looking at the carbon footprint impact, right, here. So there are a few advantages when we look at telehealth if it is implemented in the way it is supposed to be, right? And just looking at the scale, sheer number of this platform, the total patients served has been 200 million as we speak, right? And if you see the graph, you would suddenly see that this rise happened somewhere when the COVID hit us, right? Before that, for 2 years almost, the government was trying to go around and tell people about telemedicine. Nobody was interested, right? Neither the patient nor the doctor was interested. The COVID flung it open. And I think the biggest piece here was that the government changed the policy, and that is where, when we look at digital health policy, we've talked about it in previous conversations, policy becomes extremely important. If the policy system of a government is not agile, okay, thank you. I got a warning here. So if it is not agile, you will not be able to implement technology, right? When COVID struck in India, the first thing the government did was it allowed teleconsultation to be a formal mechanism of a doctor to patient connect, right? And that's where these numbers suddenly moved up. And if you look at 24, we are sitting in January. If you look at the spike which is happening in about a year, is that it's not lost steam after COVID, right? It's become a recognized method of engagement between the patient and the doctor. I'll just quickly skip this slide because I've already talked about the engagement which we've had with the eSanjeevani platform, how we've supported capacity building, how we are supporting capacity building for other countries. For example, Fiji is one of the countries where this technology is being transitioned, and we've done some capacity building with them. We are supporting CDAC, which is the organization which built this. In a lot of capacity building pieces. Very quickly, 2 use cases which have been extremely successful with this telemedicine platform has been the ICU. So it's a tele-ICU system wherein you place the equipment where the specialists are not available at a lower level, a secondary level facility, right? Which the data is then, seen by the specialists who are sitting at a higher level facility, because we have an issue of health workforce, specialized health workforce is premium as far as India goes. And they're able to see that data and able to advise the doctors, down to be able to use that. To be able to administer, the medicine and the treatment at the lower facility, right? And the second similar case is that of of something known as the SNCU, which is basically a unit for the sick newborn child, right? So now, again, like I mentioned, the specialists are few, and therefore, this was again a very interesting example which was done. Nagpur AIIMS is basically the All India Medical Institute of Sciences in India, which is one of the most premium institutes in India as far as healthcare is concerned. They were linked up to the lower level facilities, right, wherein they were able to look at children who were sick and needed more advice from the specialist. So these two systems, in fact, are already working across quite a few hubs. These are a couple of pictures, of those SNCUs and the ICUs and the teleconsultation happening based on the data which was shared, through this telemedicine platform. So it is eSanjeevani at the backbone working for both these pieces of work. I think I've finished, and this is my last slide. Apologies for having taken another 4 minutes, I think. I mean, it's not about digital health. I think it's about health till the time we realize that digital is only an enabler, and we need to do a lot of work around digital to ensure that, it is able to give you the kind of results which you are looking at. And we follow a very simple philosophy when we work with the governments is to listen, prioritize, connect, and sustain is extremely important for us. Thank you so much.
Thank you. That was really an amazing presentation and really enlightening journey for us into the remarkable work that the PATH has been doing to ensure telehealth reaches not only the most remote location, but also the individual doorsteps. Understanding that we are now towards the break, we would like to...
Yes, so now we'd like to request everyone to take your break, enjoy some snacks and drinks, and we'll be back by 3:35.
Yes.
Is that correct, Dimple?
Yes, in 15
3:35.
minutes.
In 15 minutes, in the same room.
Yes,
See you
and
soon.
we do have two more exciting presentations from Thailand. One is the case study and one is the government's perspective, followed by a panel discussion. So stay tuned, do come back and take your coffees and do come back. From their coffee break, but we can still start. Since the afternoon, we have heard about, we started with what telemedicine is, how do we define digital health, e-health, and telemedicine. Then we learned about the building blocks from Estonia. This was followed by a case study from Singapore, where Dr. Chileng presented about Sandbox initiative. And then we had from India, journey talking about how development sector engages with the government sector. Now, moving to Thailand and coming to Thailand, we would be hearing from our next speaker who has an intensive experience of setting up a startup of telemedicine in Thailand. And his experience extends beyond that. And today he would be speaking. He's not just a doctor, but also CEO and co-founder of Health at Home. And today he would be speaking more about it.
Yes. Thanks, Dimple. Most definitely. I'd like to introduce Dr. Kanapon Pamratpapin, based in Bangkok, Thailand. As Dimple mentioned, CEO and co-founder at Health at Home. His expertise stems from roles at Bangkok Hospital, the Mount Sinai Hospital, and Thammasat University. He brings a diverse skill set, including healthcare, internal medicine, creativity skills, and healthcare management. Passionate about transforming healthcare, Kanapon envisions a future where Thai people, can access medical services easily from the comfort of their homes. Without further ado, please kindly welcome Dr. Kanapon to the stage.
Hi. Thank you. Thank you, everyone. My name is Dr. Kanapon. I'm based in Bangkok, but actually this is my first time to join PMAC, right? So it's very excited to be around a great superstar in public health and academic. So I will share the cases of my company, right? I used to be a doctor. I'm going to med school, working in rural hospital, become a director of the very small rural hospital. And then I go training as internal medicine and geriatric medicine at Mount Sinai in New York City. And 8 years ago, I just started a startup. At that time, you remember they have a startup booming in Southeast Asia. A lot of VC come to Thailand, and I see a lot of people and want to follow your dream, something, quit my job to start this company. Not sure how it's going to be end, right? So currently, what Health at Home is doing, we opened for 8 years. And screen? This one? Okay. Okay. So. Wait a minute. Okay, sorry. Okay, so now we're doing 3 separate services. The first one is the caregiver service. We service people home care. We send the caregiver, and we monitor with the app with the caregiver. And second one, we open the nursing home facility. Now we have 2 branches. And the last one that we're gonna talk about today is the telemedicine. The telemedicine is a very first initiative. When I start the company, I really have belief in telemedicine, but at that time, 8 years ago, the regulation is not allowed yet, right? Telemedicine around the world is not like as a normal. After COVID hit Thailand and in global, and the Ministry of Health have the regulation, and they have a framework how to apply the license for telemedicine. And at that time, I think that I'm talking with my team. This is the time that we should do the telemedicine, but before do the telemedicine because we are private company and we have to survive by the profit, right? And if you look at the telemedicine company around the world, most of them are lost. They don't have a profit. They burn all the money. They raise a lot of fund and they burn a lot of money. And so we try to see that which angle that we can survive in this market, especially in Thai market. If I say this because Thai market have unique in terms of telemedicine or in terms of healthcare, because telemedicine actually they have 2 edges. The first one is affordable, right? The cost is cheaper, right? So in the US, telemedicine is quite work because it's safer cost than go to the hospital in the US, right? And another edge is the accessibility. In China, you can see this model is work. We doctor, people in far from the capital city in China cannot access to the doctor, so it's quite work. But in Thailand, affordability, we have UC. Everybody can access, and it's very accessible. Like they have a lot of pharmacy, a lot of clinic and hospital, right? So we have to find what angle that we could add the value to all the stakeholders. So we found one is the B2B, right? The B2B, like, and the corporate, right? The corporate, they buy the group insurance, the private group insurance, right? And we can think that the telemed can lower the cost of the public insurance because the private insurance, because the cost is safer, I think 50% compared to they go to the hospital, the private hospital, right? And the employee is happy to get the benefit. The company, the HR happy, they don't have to pay anything more. They can add the value what they build on top on the welfare that they already have, right? So we focus the telemedicine on the B2B, so we call it telemed for corporate, and we call it health at work. I will show you the commercial ad that we just do it. We will launch it next month, so you see it before we share on the private, right? So let's see. Could you click on? So we collab with the rapper artist to do this ad, right?
ไอคอกแคกเข้าไปเซิร์ชอากูบอกว่าเป็นมะเร็งที่ขาปวดที่ไหล่เข้าไปเซิร์ชพันทิปบอกว่าซิฟิลิสที่ตาแล้วมันจะดีกว่าไหมถ้าเรามีหมอส่วนตัวแค่แชทผ่านไลน์ก็รักษาได้ชัวร์งั้นแอดไลน์มาที่ @health@work พิมพ์ปุ๊บตอบปั๊บตอนที่คุณเหอไหนจะโรคยอดฮิตของมนุษย์ออฟฟิศโควิดไมเกรนนิ้วล็อกข้อติดจะอยู่ที่ไหนก็คุยกับหมอได้แค่แชทผ่านไลน์บอกเลยว่าง่ายถ้าคุณเจ็บป่วยจะจ่ายยาทันทียาส่งถึงที่อันนี้คือดีมีใบรับรองแพทย์แบบโรงพยาบาลการันตีบริการดีเป็นมิตรกับมันนี่แค่มีประกันกลุ่มบริษัทก็ใช้ได้ไม่มีค่าติดตั้งหรือสัญญาเลยใช้ง่ายไม่ต้องโหลดแอปอื่นนอกจากไลน์แล้วให้ Health at Work ดูแลข้างกายเพราะว่าหมอออนไลน์ต้อง Health at Work หมอออนไลน์ต้อง Health at Work รักษาง่ายไม่ต้องไปโรงพยาบาลแชทมาถามอาการที่ Health at Work.
Okay, this is the Friday app for entertaining the HR corporate and all the employees. So sorry for the Thai and we don't have the sub English title yet. Just get the sense of that. Quite enjoy to do the rap. Okay, so that is Health at Work. So that is the segment how we start, right? And after that, I will show you how we roll out the product, how we think about the feature, how can we go. Okay, so we are the virtual. We have a physical clinic, and we provide the telemedicine. We have to partner with the pharmacy to send the medication, right? And so now we have around 200 pharmacy that in our network, right? So we can service around all the countrywide, but mostly in the city that have the last mile delivery, right? We partner with Grab, Lineman also. And this is the office not far from here in near Jula Longkorn, right? So this is the office and also the register as a clinic. And when we think about telemed in Thailand, actually they have many startup, many service that have telemedicine platform. But if you see the adoption rate is not that much, right? I think the number one is people is not want to download more app. I think that's our assumption because too many apps right now. And so we think that, okay, so what is the friendliest platform, right? So in Thailand, for sure, we use Line, right? So we not build an app, we build on top the Line. The Line have many features that we can build a mini app on the Line app, right? So people, when we introduce Health at Work, we just open the Line app. Everybody in Thailand can use it, like from the maid to the CEO. The second one, the model that we use, mostly the telemedicine, they use the marketplace model. We see if doctor available, you have to make an appointment, right? But I think that the sense of telemedicine should be really convenient, like you talk with a friend, right? So this experience is coming from I am a doctor and my friend, or you, maybe you are a doctor. A lot of people consulting you to the app, right? And I said, oh, this is the experience that you have, the doctor as a friend. So all the doctor is, we on our full-time worker, so they have the standby. So when people, the patients come to consult, you get instant response. And we have no time limit. I think that's too much pressure. Okay, so this is how Health at Work is operate, and we open every day, 365 days per year, so no day off. So we ready to stand by. But we open on the 7 to 11 p.m. right? At first we open 24 hours, right? But if you see the use rate, it's very low after midnight because if that emergency, they go to the hospital, right? So the frequency is that low, so we try to squeeze the time to 7-11, right? So this is the workflow that when employee want to onboard our platform, make it very simple, and then we deliver the medication, right? So for the company, they not have to pay anything much. We just use on the group insurance. We get 29% satisfaction, and we lower the expense for the insurance, right? So they can keep the premium. They don't have to increase the premium next year. So that's the model that we work with the private insurance. Okay, and we work with a lot of HR, and from the user perspective, they save time for sure. That is the magic of the telemedicines. And all the satisfaction that come to when we talk to the HR, that you have get the brand employee branding. And another very key important is about onboarding, right? It's not easy for people to download the new app, right? So we have to do onboarding. We do health talk. So we come to have the activity. We work with the company or work with the insurance. Then we come have health talk. The doctor come to talk about the health issue. And maybe offline, maybe sometimes it's online, right? And we also work is sent through the email or something. And this is very successful about the health talk, right? And we also use the data when we work with the company. If we see the data, like, oh, this company, they have a lot of low back pain, so we can make the program, the campaign with the company that how can we reduce the low back pain rate, right? So we can do like a more wellness. And also another hot issue right now is about mental health, right? So people, like this generation, very stressed, so we have the panel about the mental health wellness, right? And the last one is quite gimmick, but very important. So when they onboard, we think about how can we get people, like all the employee on board, because we have one time to talk, right? So we call it the health spirit animal, right? They have 12. So everybody who register on Health at Work, they have online survey, and after the online survey, you will get one type of spirit animal, right? It's define what health are you, right? And it's quite fun when the people get their spirit animal, they talk with their friend, what you get, and then they have discussion. And people who don't get it, they want to onboard on the Health at Work. That's how we use the funny thing to make it roll out in the company, right? So this is the journey so far for Health at Work. We come to the 3 years. We serve, we have 20,000 employees that use our platform, right? We want to do more impact. Last year I heard that Ministry of Health and UC, they have some campaign about UC for telemedicine UC, right? And we were interested. I think that's very challenging initiative, and now we start to apply and learn how can we grow up and make more impact more broader, right? So this is story of health at work that we're doing so far in Bangkok, Thailand. Thank you. Okay.
Thank you so much for your presentation. Since we learned about the private sector and how the telemedicine is now being integrated in Thailand, let us invite our next speaker, who is from the government sector and who will be sharing his perspective on what the Thai government is doing to integrate Thailand and integrate telemedicine in Thailand, and also to adopt as well as implement it at a larger scale.
Yes, definitely. Dr. Suparek Tawilap is currently the Director of Epidemic Intelligence Unit, or EIU, at the Ministry of Public Health of Thailand, a senior professional level medical doctor, as well as preventive medicine specialist. His background education covers two very specific and intertwined fields of expertise. So this includes digital health as well as epidemiology. So very perfect and fitting for this topic, which is the most relevant in the current situation as well as the future crisis. So please welcome me to the stage, Dr. Suparek.
Okay, good afternoon. This is the last session. So I will make sure we'll make it concise and quick. I have several hats on my head right now. The first one is I'm deputy of the ICT centers of the Ministry of Public Health. First, I'm going to tell you that Thailand, talking about telemedicine, we have been trying for 5 years. This is, sorry in Thai, but I just want to make sure that it was the Thai government missions to support the Thailand digital economies and societies as a part of the government actions. And just to show you that it's here, it's what written in Thai, and here telemedicine is already part of the government for several years, 5 years already. That's a little bit pretty long. And we also put the plan trying to put in our actions with the collaborations between the ministry. I'm from Ministry of Public Health, but this slide is from the Ministry of Digital Economy, which is more like ICT of the government. So you could see that this is from the Ministry of Digital Economy. They are also talking about telemedicine. So telemedicine in Thailand as a government officer is more like a collaboration between multiple ministries. We work together closely with several ministries: Ministry of Public Health, Ministry of Digital Economy, Ministry of Science and Education, and so on. It's more like a government mission rather than the Ministry of Public Health alone. And talking about telemedicine, which is going to be similar to all the presenters that already present so far, is the growing trends, and everyone has been using telemedicine for saving costs and improving access to health care, which I'm not going to spend much time on it. But in Thailand, besides from the ministry that I already mentioned, besides from the ministry, we also have collaborations among the, the councils. In here, we show the 4 councils of Thailand. This is the Thailand Nursing and Midwife Council. This is the Medical Council, Pharmacist Council, and Dental Council. But I would say that every single council that involved in the healthcare system also have their own regulation, which is, you could see that there are several papers and regulations around here. And it's our job as the Ministry of Public Health to collaborate and resonance with a whole. So it's more like the nursing have the tele-nursing regulations. The pharmacies councils have their own tele-pharmacy regulations. And dental council, they have tele-dental regulations. So a little bit confused, right? But that's our job to resonate everything together And of course, with Dr. Pataravin sitting here, we'll do this important mission for us. Thank you, Dr. Pataravin, for your hard work. Okay. Oh, again. Okay. Sorry. Okay, so in Thailand, before the COVID, we already see a very good percentage of the hospital using telemedicine in Thailand. This statistic is pretty old right now, but even though you could see that it's already 74% last year that hospital that have some kind of telemedicine service available. I would say that every single mean of the telemedicine, including the specific telemedicine platform, private, public, or even the Zoom applications, the team applications, we also use that in our service as long as it complies with our regulations. In Thailand, well, you could hear that some countries will have maybe one or two single national telemedicine platform. But in Thailand, we'll use a little bit a different approach. You can see that on this screen, there's already 27 telemedicine platform in Thailand, and this is not the most robust one. Right now, it's more than 50 platform in Thailand. As long as they comply with our regulations of the reporting system, data standard, we are good as long as they are comply with our standard. So you could see that there are several varieties and it's enhanced the competencies and competitions among the vendors. And of course, the most benefit from this is our citizens and our patients because they have so many choice, so many alternatives for telemedicine in Thailand to suit their need. And we had already talked about the past, and we are talking about the futures for now. As me, as the governments, what we are going to do in the next 3 years, or even this year. All of the presenters talks about digital transformations and digital health, which is true. And I'm going to start with the same as our colleagues from Singapore in the COVID-19. I know that every single country in this room will have experience using some kind of apps and several digital transformations what happened during COVID 3 years ago and even now. I'm not sure whether it's still available on the international today, but at that time in Thailand, we also trying to comply with the vaccination certificate. It's right 3 years ago, but this is more like a case study of how the digital transformation from this paper-based system to the application system. And of course, it involves telemedicine. Sorry. Okay. Okay. And of course, several countries are already trying to utilize their platform before the COVID to the post-COVID transitions. This is the bird's eye view of the digital health platform of Thailand. In Thailand, we have an idea that telemedicine is not a standalone application. It's not just an app. So it must connect to the whole healthcare system, digital healthcare system. So this is the reason why I mentioned earlier that regardless of the vendors, telemedicine, if you have your own apps, Health at Home is okay, as long as you are comply with our regulations. If you comply with our data standard, you are part of the platform of the world countries. If you want to, it's not necessary to have a single app. And this is the diagram that we used during the COVID-19. It starts with direct connections to the electronic health records of the hospital, pharmacies, dentals, private lab, and to the Ministry of Public Health data centers. We also have business intelligence, which right now is already have the AI and several data science working on analyzing the data. And we also have the connections to the people, which the means of the line applications and also the smartphone applications. Yeah. I mentioned this because before the COVID, everything was in paper. I mean, everything right now. You never see hospital that using everything in electronics, but many things is in papers. And of course, with the papers, the hospital that are using the papers, they could not use electronic prescriptions. They could not use digital health platform. They could not connect to the smartphone. How can you connect? How can you digital transformations the hospital that using the papers? The hospital with the paper-based system won't be able to connect to the largest platform, regardless how good the platform is. Because of that, we realized and we learned during the COVID-19, the top-down approach alone won't work anymore in the post-COVID era. So regardless how good the platform you are, if the hospital is using a paper-based system, it won't work at all. In that case, we try to come up with the policy. In Thai, we will call, I know people already heard the words, but ประชาชนใบเดียวรักษาทุกที่ but in the English, we will call them one ID card smart hospital. This is the current team and the current Ministry of Public Health policy. What do I mean by one ID card smart hospital? Well, actually, the function is mostly the same, especially our presenter from Estonia. You see that the slide will look a little bit similar to your presentations. There are several functions that look alike to several countries. We put it into 4 categories. Electronic health records. Well, of course, if you don't have electronic health records, you have no ways to connect to a larger system. The second one is digital patient ID. It includes the master patient index. You could see that it's more like an index. Your citizen ID or your patient's ID that we use as an identifier across the larger system. The service innovations of the third component is similar. Telemedicine is part of them. But not just telemedicine, we are talking about the e-prescriptions, the online appointment, the home wards, and so on. Every single service that we want to have is here. And also, every hospital should have the means to connect with their patients using the IOA application and also the smartphone applications. It looks similar to other countries again, but our aims here is we want all of the hospital under Ministry of Public Health will transform from the paper-based system to have everything here by the end of this year. So this is the summary of the current Ministry of Public Health actions here, which are already talking about the smart hospital is everything that I mentioned in the last slide, which every single hospital has to comply by the end of this year. And we also rebrand and restructure the hospital. Every hospital, again, will have a specific task force responsible for digital transformations. We don't want to see any single hospital having a paper-based again by the end of this year. And we hope, and we establish this special task force every single hospital to complete it. And of course, digital health will come with the AI and regulations. So right now, we are revolutionizing the regulations and clearance for medical device, including the AI, to be much easier to get approval and integrate in our system. And right now, the e-document and paperless policies, you could see that we mentioned about the outpatients, but inpatients, the ward, in hospital ward, inpatients, many of them still in the paper system, but also we want them to be in the paperless system by the end of this year. All hospitals in Thailand should be a paperless system. And of course, it is a very challenging and big project. The government, even with the power of multiple ministries, we could not do it alone. We changed our directions. Before the COVID, the government will bear the weight of implementing all of this alone. but now it's not. We will partnership with several private organizations to make it happen. This is our directions from now on. Regardless of your organization, if you are NGO, international organizations, public companies, private companies, health tech startup, we welcome you to join us and revolutionize Thailand healthcare, including the international collaborations. This is our plan. In Thailand, we start with the phase 1, which already kicked off from 7th January, which you might have seen in the news. And in March, our phase 2 will kick off among these 8 provinces, and the phase number 3 in April. There are 4 regions that will implement these projects by the end of April. And of course, by the end of this year, 2024, every single hospital, every single province who have smart hospital will become a paperless hospital by the end of this year. But we are talking about paperless system. We are talking about apps. We are talking about everything that looks very, very high-tech. But we are Ministry of Public Health. We are not responsible for the urban people in Bangkok only. We also have patients that still live at the borders of Thailand. They don't have smartphone. They don't have laptops. They might have some internet, but the speed is not good enough. Even the cloud computing is pretty limited here. So, but everyone have this card. The Thai citizen card here, regardless of your age, regardless of your income, regardless of your locations. You will have this card. You could see the ladies here is disabilities in the rural area of Thailand. She still have this card. She doesn't have smartphone. She doesn't have the laptop or anything high tech, but she have this card. So we will leave no one behind, and by the end of this year, you could see a revolutionized in Thailand healthcare system, and we hope all you will have achieved these missions. And thank you for your time.
Thank you, Ajahn Suparik. That was a lovely presentation, and we truly hope that by the end of this year, Thailand becomes paperless and we leave no one behind. That being said, we move to our last session of the day. Don't worry, we'll not keep you too long. It's just a quick 20-minute panel discussion where we would be discussing the perspectives from different countries that we have heard so far, and also what are some key challenges that they must have encountered, and what's the tomorrow that prevails for telemedicine. So with that being said, our next speaker, Dr. Ali Habib.
We have Mr. Ali Habib, consultant senior digital health specialist with the World Bank. In this role, he advises World Bank teams and government counterparts around the planning, budgeting, and also the implementation of World Bank supported digital health initiatives. Mr. Ali has 15 years of experience with digital health planning and implementation in LMICs. Please welcome Mr. Ali Habib.
Yes, Mr. Ali Habib will be moderating, and we'll also invite all our speakers to please come and take your seats for an interesting discussion.
Okay. Thank you. As we ask the speakers to come and sit, I'd like to invite my colleague from HITAP as well to sort of share with us another platform to talk about AI and health as well in the upcoming conference. So please, let's hear a bit from my colleague Sarah.
Before we move on to the panel discussion, I would like to take this opportunity to shift your attention to the 14th Priorities Conference that will be hosted by HITAP this year. It will be the first ISPH conference held in Asia during 8th to 10th May here in Bangkok. As you can see, some of the topics that the plenary sessions will focus on is AI and RWE for informed priority setting, early HTA, balance between efficacy and equity, environmental sustainability, and crisis prioritization. You can scan the QR code above to register, and please note that registration will end on the 31st of March this year. And for more information, please follow www.priorities2024.com. Thank you so much, and we hope to see you there.
Okay, so thanks first of all to our speakers for taking the time to share your experience today with this group. Thanks everyone for attending. I know we went off schedule a bit, but we won't keep you very long. So, we noticed some interesting similarities and differences across the speakers. In for example, Estonia and Singapore, we had typically well-connected environments, high infrastructure settings, and a smaller scale compared to countries like India and Thailand. A smaller scale in terms of geographic scope, in terms of population. And what I'd like to sort of get from all of you, kind of one by one, is when you said about implementing digital health or the sandbox or the e-Sanjeevani system, or when you were working in the private sector, Dr. Kanapon, and when Dr. Pai was looking at setting up telemedicine in the country, could you sort of surface some of the key challenges that you faced when you were doing this, and how those were addressed? And we can just go one by one on this, but that's important to bring out because there'll be different challenges in different settings. And it's important to surface that so that people get a sense of what those key issues were and how those were addressed. So we could just go one by one on this. There's no particular order. You guys can just jump in. Or I can call on people if that'll help.
Okay, let me take the first this thing. So I think there are a couple of them. So when we are looking at policy, I think that's one key issue, right? So there have to be policies in place to allow you to use digital systems. That's one. Second is, we talked about the infrastructure now, and I think we were discussing this at lunch as well, right? In terms of, for example, let's say if I pick up the example of India, 80% of Indian families have at least one smartphone, but the balance of the 20% are the most vulnerable and where we need to reach. So how do you ensure that, when you are looking at digital, you are reaching to equity and not creating more inequity, right? So that's a huge challenge. So programmatically, you have to look at when you are implementing technology, is it going to help or is it going to probably create more issues for you as you go forward, right? Third, I think, is the capacities piece, being able to at the lowest level, being able to use the digital tools, understand their usage. And lastly, I think it's how does the data which you get, how does it blend towards more decision making, and the policy pieces of it? Does it actually close the cycle when we look at the data coming in? Does it help me get better policies in place or not?
Thank you. Anybody else?
Okay, so for me, the key challenging when I start the health at work, I think the first one is regulation, as you heard Dr. Pai, that we have many regulation from Ministry of Public Health, from Medical Council, from the insurance regulation, and so everything is quite dynamic, right? So at first when we start the service and we use the cloud service, and they say, oh, you cannot use cloud because you have what cloud do you use? I say, I will use Google Cloud. And they say, oh, it's not keep the data in Thailand. So that is quite violate the regulation, right? They say that is quite challenging for us, right? So I think that to work with the regulation, I think that we can see the public sector is quite very innovative and have the young blood to coming and hopefully. And so we have to work it. But that is the main challenge, very, very frustrated The second one is about the user. And when we do the telemedicine, I not start from the corporate sector first, because we used to do caregiver service with the elderly. So at first we think, we should go to use telemedicine with the elderly, right? But it's very difficult to educate the baby boomer generation to use telemedicine. They say, why do you talk with doctor in the mobile? Why you not go to hospital, right? It's very use a lot of resource, right? So that's also the experiment that challenging to learn that which segment and which the user is most receptive for the new services, right? And that's for me.
So because you already mentioned about Thailand, so I would like to add on from the point. He already mentions the regulations with a very challenging one, and it still keep change even today. So we have to try to update. Even me at the still have to care a lot. So what I would like to add is the diversities and the varieties in the infrastructures across the hospital in Thailand. We have 10,000 hospitals on different levels, and of course. The IT system, of course, they are very challenged one by one from each hospital, but not just the program, also the electricity. In some hospital, in some case, we try to use cloud-based applications, but on some day they just have a thunder attack and the electricity just running off for the entire province, and they could not use internet at all. So that is pretty challenging, and this is a very different challenge on one by one. Some hospitals have very own PC from 30 years ago. I think it's Pentium 2. That's a very old one, and a Windows 95, for example. Even so, they are not compliant to the new application as of today. They cannot install at all. It is a very challenging for us. So we try to address by we just don't want to support you with telemedicine applications, but we also have to support you in terms of infrastructures, internet, PCs, and even the electricity. And we also have standard tools for them to use. Some hospitals are very small and don't have that.
Couple of things. One is utility for users. I think sometimes IT is a language from a different planet, and getting health professionals to adopt the technology, I think it's always difficult. They need to see a value in it. Their work needs to become easier. So the other one is managing privacy and data protection. It's I think European Union in general has very strong privacy rules, but for example, just allowing data to be exchanged, personal data. In Estonia, it's issue of trust, but it's also an opt-out policy. So opt-in, automatically everybody has agreed to allow their data to be shared, but they can opt out if they wish so. And third one, perhaps we never attempted to build a big system for every party in the system, the health system. We have hospitals, most of them have their own management information system. The family doctors have their own, they have a couple of those. So all these systems need to connect. So the managing this interface, I think I think that was the key, that from the e-health system side, you are very clear about the standards, and then let there are private contractors working with different providers to actually make sure that the output of their system fits the input standard to the system. So, but if there is a clarity, it will be done. So, and finally, perhaps it's not really a choice right now. Right now, this time, you can't be a healthcare provider of any kind, private or public, if you don't have ability to connect with the system. So.
And Jim, you want to share something from Singapore?
Yeah, can you hear me? I think Singapore itself is a microcosm also of the kind of digital divide that is experienced in many places, with the exception that we don't really have a rural-urban divide. I remember consulting for the Vietnamese government, and I realized majority of the population was living in rural places without necessarily access to smartphones or internet connection. So that was really challenging. But it's no less challenging in Singapore. I think for some of the elderly, they generally don't use smartphones, so a lot of this is not accessible for them. The way that we've tried to circumvent this is to say, could we activate family support? So empower the children and the caregivers and build the tech tools to support them, by proxy, support the elderly. So I think that empowerment of caregivers or even nodes in rural areas, maybe not every villager might have smartphones, but perhaps there are centers within the village that could do that by proxy for them. That's one way to think about this digital divide and how best to circumvent.
Great, thanks everybody. I want to pick up on a couple of these, maybe to do a deeper dive. I think one that comes up often is security. And security is a big word. So when we say the security of this data, what aspects of security did you all consider when you were, in your experience, and how much of a burden was that to address? Because very often we put systems into place and then security is an afterthought. And so there's security in terms of the actual safety of data to prevent somebody from kind of breaking into a system, a malicious actor. There is security from the perspective of privacy and confidentiality, and Dr. Tomas sort of alluded to that a little bit. And then there's security in terms of data in transit, data at rest. So what aspects of this security have you all kind of, in your experience, seen be issues or be thought of, or how did you approach this and how did you kind of address those things?
Well, I can start. Sure. Security is really fundamental to trust in any system. There's also no foolproof, or there's no such thing as a 100% safe system. There's always going to be vulnerabilities. I think the main thing that mitigates that, apart from doing your due diligence and making sure the safeguards are in place, is just having a really good team that can respond in the event of a breach or an incident. As long as that is in place, things are usually recoverable. Of course, there are cyber attacks and all that would be harder to recover from, but that one is also a function of the quality of tech team. Because if your tech team is good, they would have thought of ways to defend the system against different vectors, different threat vectors. One thing I would caution is that I think the security threat can sometimes also be overblown. Yes. And the cybersecurity industry is a many $million industry. I do sense that sometimes some of the threats are amplified beyond what it actually is. And it comes from sometimes regulators or officials that may not really understand the tech could buy into those buzzwords or buy into those sort of cybersecurity speak without really understanding what the core issues and core threat vectors are. So that's just one cautionary note.
I will add on from these cases. So I think that regulation try to protect the downside, and they have many laws, but sometimes it's too much on the protection. Like we have the regulation is coming in from medical council. I think that they say that if you provide telemedicine, you have to record the video, right, all the session, and you have to keep it like in 10 year, 15 year, right? But it's in terms of the cost structure, that's huge. If you know like how many gigabytes you have to keep it and protect it as long as, right? But it doesn't make sense actually, because if you go to the hospital, when you go, you don't have record anything. You have just one summary, right? Doctor record, right? But why telemedicine? You have to record all the thing, right? So that is really challenging but I understand perspective of the fraud protection, the risk management, but sometimes it's too much, and if they not see about the cost, what's happening from the entrepreneurial side, so that is challenging, and that is challenging for me.
Yeah, actually it's the same challenges for us, the material health as well, because it's like a digital divide that you already mentioned. For example, if you visit the hospital maybe around here, I would say that most of them comply with the European Union GDPR regulations and also have several sophisticated cybersecurity system. But in the rural area, if I say this, they will just ask, I don't even have the money to buy new computers, and you are asking me to comply with the European Union regulations. That's what they really tell me. So for us, it's pretty challenging because the one thing's very complicated security system, and one have nothing at all. So for us, we have to it's more like waiting, like you already said, the cost, the risk, and the cost that we can afford. What is acceptable for us, the ministry, for the hospital of this level, this is they require much higher risk security. So we try to adapt the regulations that can improve the overall security of the health system, while still the cost is still reasonable for them. You don't want like a very small hospital to just buy like a multi-million US dollar of the security system, right? So it's more like a risk and a cost benefit for us.
I think there are a couple of aspects to it. One is the kind of systems for data security. They need to be continually updated. When I come from Estonia, Estonia was the first country to be attacked with electronic warfare. I think it was maybe 10 to 15 years ago. The result was that the NATO cybersecurity center is in Tallinn, and the same for EU cybersecurity or IT security agency. So this needs continuous vigilance, but I think the real risks are more about perhaps the user side, the behavior side. You saw, I showed the electronic profile, and there was a segment trying to educate the population about simple cybersecurity principles. If they access or they share their data, that's one. And also there are agents who have been authorized to access data, and they may take some data out for operational reasons, and suddenly this get hacked. We had this case maybe a month ago where some genetic testing data, including paternity tests, were kind of hacked. But they were sit in an organization that was not authorized to keep them. They had so these things happen, but these are behavioral things. This is not kind of their system fault.
Just to add to that, I think we are still evolving when we look at health data, right? And probably at some point in time, we need that, minimum levels of security which we are looking at, or cyber security for that matter. And second is being able to define different levels for the data which you have, right? For example, let's say, to me, the HIV data or what he mentioned, genetic data might be more sensitive than normal hemoglobin and HB. Right, so I think we still need to work out these policies, right? And these are very specific to geographies and countries, right? I mean, we have our own set of sense of security and the trust which we have with the system. But I think we also need to look at that this should not become a blocker, because I mean the data is sensitive. Let's not make it oversensitive, right? Today, I mean, we are interacting with the digital platforms in X number of ways, right? And there are leakages which are happening. I can give you a personal example. There is a delivery mechanism in India known as Zomato, a multi-million-dollar company, right? They lost good about, I think, 2 billion data just about 2 years back. My own data, all my addresses, all my phone numbers, my age, date of birth was available on the darknet, right? So these things are going to happen. This should not be impeding us to adopt technology in the health sector. Obviously, we need to be sensitive. The countries need to have frameworks, but I think we need to also define levels of security when we look at data and structured data sets in a manner where some pieces are accessible. Anonymization needs to be looked at. I think we not talked about it, but for health sector, the anonymization of data and the availability of data for research is extremely important in the health sector, right? So therefore, you can't be saying that I'm not going to share my data at one point in time. You need to look at anonymization in a huge manner when we look at the health sector. I think that's one aspect which just not being talked about anywhere, unfortunately.
Well, thanks very much. I think it's very important the points that were raised around not overblowing the security kind of concerns, so that it becomes an impediment to moving ahead, but to keep it in mind and to sort of tailor systems accordingly and policies accordingly, and all data is not the same. does not require the same level of security, perhaps, and it's important to kind of differentiate between those layers. One more, well, a couple more. I think one is on the payment to care providers. And this is obviously a key part of what makes these systems work or fail. And there's two aspects to this, right? One is obviously the systems that have been set up to reimburse providers for the care they are providing. And the other one is the attitudes of doctors to that process. In my experience, no offense to anybody, doctors are very hard to get to change the way they operate. And so from that perspective, both from the reimbursement perspective as well as their attitude towards providing care this way. Somebody said that the elderly doctors over lunch, I think we were saying that were more resistant to using telemedicine, and the younger ones perhaps were more eager. But if you're looking to do this kind of at national scale, at different levels of tech literacy, at different societal kind of attitudes towards technology, so how did you address those kinds of differences across the provider spectrum, both in terms of kind of attitude to the tech as well as to the reimbursement?
Okay. I'll pick up an example of what we faced, right? And then when we had this very specific piece which you talked about, we had a brainstorming session with the big wigs in India. So I think one of the points which came up was that, you need to catch them early because, unfortunately, there is no digital health when you are teaching them medicine. So I think that's where it starts, in the medical colleges, right? So, I mean, if let's say the medical colleges are giving you internships and they are linked to hospitals where these students are going and giving service delivery, I think if they are digitized, so they learn it early, right? They understand the nuances and probably the next generation at least comes prepared out of to be able to adopt digital pieces. But you are absolutely right. And then when I showed that slide, why this sector has lagged to adopt technology is largely because the doctors are not very keen. And we talked about, the paper records and the text which you mentioned. Unfortunately, we are also going that way, that we are saying that, okay, just click a photograph, make a PDF, have a wrapper on top of the technology, right, to ensure the record is available. But then if I am really looking at the health data into it, it's not available because we know if we try and start there, we'll never be able to accomplish what probably we want to. Unfortunately, these are facts. We have to work around them. But largely, yeah, this sector has a huge amount of inertia in terms of being able to adopt technologies. Unfortunately, at the higher level, the technologies which are available are people are more than willing to adopt technologies, right? When you are looking at specialized care. But unfortunately, when it comes to that population level, primary health care, that's where I think there's a huge gap.
Okay, for the reimbursement challenge, I because here at work that we work in two schemes. The first one with the private insurance, and I have very funny story. When we early start, we work with private insurance company, and we work with the innovative team, the digital transformation team. That is quite common in the corporate world, right? Digital transformation team say, yeah, we want to do the telemedicine. It's a new way of the insurance, right? Okay, and the CEO say, okay, let's do it, right? And then we roll out, and then the claim department say, no, we not pay you the money if we don't have the paper with the ink sign. So what we have to do, we have to call the patient. Could you print your ID card, sign it? I will send the message to pick up at the first early year. That's very funny, right? So it's quite that people want to move fast, but the legacy of the infrastructure is quite challenging. And another insight that I can share is about B2C. We also have some people come to use our platform and they pay out of pocket, right? The challenging is, if you use telemedicine for the B2C, will you charge the patient first before using the service or after? That is very key challenging, right? Right. So what we do the A/B testing, right? If you charge first, the drop off is about 70%. So they want to pay, right? They feel this is new. I want you to pay upfront and something, right? But we do the experiment that we charge after. You just come, we consult, we give prescription, everything, and we charging in the end. Do you know how who like can run away, who not paying? It's just 2.5% actually. So it's quite low. But when we have small base, right? But it will be gets more. But we can see that just 2.5%, right? So that's very new insight that people when they talk with the doctor, they feel that okay, we want to pay just 2.5% drop off. So now if you use here at work, we charge in the later, as the rate is not more than that, right? All right.
You are right. We use several means, and reimbursement is one of the means. Besides from the reimbursement for the hospital, there will also incentive directly to the doctors that use telemedicine. For example, they will get addition add-on for their service. So in other words, they will gain more money. But even though some doctors still don't want to use it, so we have several means, including the KPI directly for each doctors, and even if that doesn't work, so we have another means. Instead of using doctor, we are using patients. In Thailand, people have to spend maybe 3 hours just to travel from their home, waiting for a long queue, and before they see a doctor, maybe around 5 minutes. So we try to set up with a several service that, okay, if you can try using this telemedicine service, and when patients impressed, wow, I don't have to spend 3 hours. For example, in some province, we send a rider and messengers put with their own personal phone and set up telemedicine to the patients directly, so they don't have to come to the hospital. And when they really like this service, they will directly request the doctors, I want to use this service, doctor, please do that to me. If you don't, I'm going to switch doctors. And that works a lot during this day.
No problem.
Cool. I will move country.
I thought you'd say that. Anything from Singapore?
I think telemedicine is really just a subsegment of doctors that use it. So for those who do, they're generally already IT savvy and IT literate, so not much of a problem for them either. Yeah.
Okay, thanks. And now a Thailand-specific set of questions, because I heard our two Thailand speakers share different perspectives about the same thing, and I want to drill down a little bit deeper without getting into acrimony. So, Dr. Kanapon, you said that prior to COVID, you had a hard time kind of kicking things off because of regulation. And Dr. Pai said that telemedicine services existed prior to COVID and were running. And I'm wondering kind of what this difference of perspectives is, because what was it that stopped you from starting when these other folks were up and running? Or is it just a kind of not knowing that regulations are in place? So it's one thing to have them in place, it's nothing to know they're there and functioning. So kind of what was that gap?
The gap is that I know that the Ministry of Health have some framework like initiate to push the telemedicine, right? But nobody is doing yet. Like the hospital is not doing yet, and it's have many gray area about the medication delivery and how can you. Is the doctor is very fearful that if I do telemedicine, if I get sued or something, that there is no something to touch by. But I think when we decide to do when the COVID hit and everybody have to do telemedicine, or the government hospital, private, everyone do the telemedicine with Line app, like I know I think that Line app, and it's okay for 1 or 2 years, and it's okay, it's more safer for us to go to do it, right?
Yes, Dr. Hanapon said that telemedicine regulations exist before the COVID. There are several have the system in place, but with very low volume because of regulation is pretty gray area at that time. But when COVID attacked us, we had no choice but to use it. It's similar to the United States that the regulations was relaxed during that time. So the usage just peaked during the COVID-19. So and that time, so we had to try to gather the feedback. Okay, what should we do to keep the telemedicine usage at this level even after the COVID-19? So we adapt a lot of regulations after the COVID-19. So that's why.
Great. Well, we are out of time. Thanks very much to all the panelists once again for sharing your views. I'm sure folks are available if you want to, meet them one-on-one as they go out. And I guess that's the end of it today. Thanks very much, everyone. I can hand it back to the HITAP team.